Have we talked about the breast on this channel? It's one of those topics which feels like as if I've taught on before, but at the same time, it's so important that why should I be feeling like it's deja vu? Anyways, grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we're going to be looking at inflammatory breast pathologies as a prerequisite to breast pathologies. If you haven't yet subscribed to the channel, please subscribe to the channel, hit the bell notification icon to be receiving notifications of such videos every time I post. Grab a piece of paper, grab your pen, and let's go. Here's a warm-up question, which is a true or false question. Thyroides tumor on histology, A, might be benign, B, might be borderline, C, might be frankly malignant, D, cellular stroma is characteristic. You may write down your answers, scream them at your screen, and we'll give you the answers at the end of the lecture. So what are our objectives in this class? We want to look at the approach to breast lumps as part of breast pathologies because it's very important to understand this as a stepping stone. Then we'll go into the different inflammatory conditions that do affect the breast. So remember that whenever you're dealing with the breast, there's something that's referred to as triple assessment. So when you talk about triple assessment, we're looking at clinical assessment, we're looking at radiological assessment, we're looking at pathological assessment. So on your clinical assessment, this is going to be entailing your history and physical examination, which I will go into details of in another separate video when we talk about the approach to the breast. Then when it comes to radiological assessments, this largely depends on the age of the patient. If a patient is below 35, an ultrasound is good for them because of course, technicalities of the breast, the size of the breast, and of course, the breast density. Then those that are above 35 are going to be getting a mammogram. And remember that ultrasound is particularly useful in patients that have lumps. It can actually help you determine whether this is a solid or it's a cyst. And remember that mammogram is good at determining whether you have a benign lump, which is very well defined and sometimes may have a surrounding halo, or breast pathologies, which may show speculations, architectural distortions, and even malignant microcalcifications. That's your radiological assessment, imaging pretty much. Then we have our histology, which can be done by the biopsies. So your fine needle aspiration and cytology, which we do, and your true cut biopsy. So remember that in fine needle aspiration and cytology, you're going to be using a fine needle attached to a syringe that's going to be inserted into the lump, and cells are going to be withdrawn by making several pushes through the lump with a negative pressure of about 6 mils. Then once you have withdrawn the cells from the breast, then you can actually either fix them or air dry them on a slide, and then you can put them on a transport medium, and then you can send them to the lab where they can actually be fixed, stained with either hematoxylin and eosine or papanicular stain. Now, there are some advantages and disadvantages of doing this. One advantage is that it's going to be allowing drainage of cysts if there's fluid that's going to be present, and this is almost diagnostic of benign pathology. And if the fluid is actually withdrawn and it's bloody, then this may warrant for further investigations. A disadvantage of this is that breast cysts are often going to be associated with the presence of intracystic papillomas, rarely, sometimes even carcinomas. And in these cases, the excision of the cyst actually may be necessary. Then some cysts can actually recur even though you drain them. And in addition to this, you are getting cells from the breast, so you're not having a good indication or a clear picture of what is happening in the entire lump. Then you have a true cut biopsy. So when cytology is inadequate or unhelpful, the next step that you're going to be doing is having a core biopsy. So this one is minimally invasive. It can be done under local anesthesia where a section of the breast tissue is going to be obtained from the lump. And the advantage of this over fine needle aspiration and cytology is that histology assessment or the tumor grade, especially with lumps that are malignant, can be established. Even the estrogen receptor status can be seen. I'll show you a picture of what this actually looks like. So here's how we classify cells from FNAC, which is the fine needle aspiration and cytology. C1 if they're inadequate, C2 if they're normal or benign, C3 if there's atypia, probably benign, C4 if there's atypia, probably malignant, and C5 if it's malignant. Remember that a C5 diagnosis on cytology is going to be congruent with the clinical and radiological features that are going to be allowing the surgeons to carry out a definitive surgical procedure for breast cancer. So here's what it looks like. So here on top you have a benign cytology. So these are normal breast cells. Then here you have malignant cytology. So these are malignant cells. You can notice the striking difference between the two images. Then here you have immunohistochemistry, which is going to be showing estrogen positive receptor stains. And then here's a core biopsy and histology showing a benign fibroadenoma in this image here. So let's talk a little bit about breast anatomy before we jump into details of inflammatory breast pathology. So remember that the breast is actually a modified apocrine sweat gland and is going to be derived from the ectoderm as branching epithelial cords which actually form the lactiferous ducts. So at puberty, you have around 15 to 20 lobes that develop, and each of them is going to be draining into a single lactiferous duct. So the true secretory alveoli actually are going to be developing during pregnancy and lactation under the influence of certain hormones, estrogen, progesterone, and prolactin. And remember that the mammary gland can actually develop embryologically as an invagination of the ectodermal tissue along what we refer to as the milk line, or you can refer to it as the intrauterine milk ridge or the anterior mammary ridge. So this is just a line that's running from the axilla to the vulva. If you've noticed, animals like dogs have multiple nipples and multiple breasts along the same milk line, and sometimes in individuals like humans, you may also have extra nipples developing elsewhere. So we call this as supranumerary nipples or accessory nipples. Then remember that the breast is going to be located vertically between the second and the sixth rib from superior inferiorly, and in the mid-clavicular line, it's going to be lying over the pectoralis major, the serratus, that's medially, laterally the serratus anterior, and almost inferior is the external oblique muscles. And remember that horizontally, it lies from the side of the sternum to the mid-axillary line. 2/3 of the breast tissue actually is going to be resting upon the pectoralis major, and 1/3 is going to be resting upon the serratus anterior. Then the lower medial quadrant is going to be resting on the external oblique aponeurosis, which of course separates it from the rectus abdominis. So the breast is going to be lying in the superficial fascia, and remember that the superficial fascia is going to be divided into a superficial layer and a deep layer. So below the superficial fascia lies a space which is known as a retromammary space. These anatomical things are very important for you to note, because this will become very important, especially when you talk about mastitis. So remember that the retromammary space is within the loose areolar tissue, and then you have the deep pectoral fascia, and of course the muscles underneath the pectoralis major, serratus anterior, external oblique, and then of course the chest wall. Keep this in mind. Then in the retromammary space, remember that the retromammary space is going to be found in the deep layer of the superficial fascia, and between the deep layer of the superficial fascia and the deep fascia, which is the pectoral fascia. Remember there are two types of fascia. A superficial fascia, which has two layers, a superficial layer and a deep layer. Then you have the deep or the pectoral fascia. So between the pectoral fascia and the deep layer of the superficial fascia, you have what is known as your retromammary space. This allows for the movement of the breast. So remember that breast comes in different sizes and shapes, and in different individuals, they may actually be characterized by fullness in the lower area. Sometimes they may be drooping or have some ptosis. I like to call these as fallen heroes. Apologies if anyone is offended by that comment. Then they may actually become much more pronounced with increasing age. So the nipple is going to be found at the fourth intercostal space, just below the center or the summit of the breast, and it's going to be containing circular and longitudinal muscles which make the nipple stiff or flat. Then it's going to be pierced by 15 to 20 lactiferous ducts, and each of the ducts is actually going to be opening independently into the breast, and these areas is going to be consisting of numerous modified sweat as well as sebaceous glands. Then you have a circular pigmented area just around the nipple, which is known as the areola. So this is pretty much rich in modified sebaceous glands, and these glands may actually enlarge during pregnancy and lactation as what we call as Montgomery tubercles, and these are going to be secreting this oily substance that lubricates the nipple and the areola and prevents it from cracking, because this may actually be one thing that may cause mastitis. Then the areola and the nipple do not contain any hair, they do not contain any fat underneath. Then the outer part of the breast actually extends into the axilla, so as what we refer to as the axillary tail of Spence. So this is just pretty much a prolongation of the outer part of the gland, and it passes up the level of the third rib into the axilla through a defect in the deep fascia, which is known as the foramen of Lange. So this is actually in direct contact with the main lymph nodes of the breast, so the anterior axillary lymph nodes. So when the axillary tail actually enlarges, it may actually even be mistaken for a lipoma. So this is the axillary tail of Spence. And of course, this is the foramen of Lange, which is a defect in the deep fascia. So remember that the breast is going to be anchored to the skin and to the underlying pectoral fascia by bands of connective tissue, which are called ligaments of Cooper. These are very important because contractions of these strands can actually cause the breast skin to become dimpled. It can also lead to attachment of the growth to the skin, and such that the lump cannot be easily pinched off, or the breast becomes immobile. So this is a very important sign, especially in breast cancer. So if the cancer actually grows along the ligaments of Cooper by binding to the breast to the pectoral fascia, then the breast is going to become fixed to the pectoralis major, and it cannot be moved along the long axis of the muscle. Then what about the histology? So remember that the breast tissue is going to be consisting of a stroma, which is supporting tissue, and a parenchyma, which is the functional tissue of the breast. So it's going to be consisting of acini, which are these circles that are going to be becoming small circles that are merging together to form lobules. Then the lobules will aggregate to form lobes. So the smallest unit is the acini, which aggregate to form lobules. The lobules form a lobe. So remember that approximately 10 to 100 alveoli, which are also referred to as acini, form the lobules. This is like a bunch of grapes on a stick. Then the lobules make the milk that's going to be draining via the ducts into the nipple, and the lobes are arranged in a radiating fashion like spokes of a wheel and converge on the nipple, and each lobe is drained by a lactiferous duct. Remember that the functional unit of the breast is what is referred to as the terminal duct lobular unit, and you have about 15 to 20 lobes that develop during puberty, each of them draining into a single lactiferous duct. Then remember that there are some hormones that actually influence the development of the breast and the production of milk. Estrogen helps in synthesis of the ductal aspect, so ductal proliferation. Then progesterone is with glandular proliferation. Prolactin is with milk production. Pro meaning before, lactin before lactation, so milk production. Then oxytocin is with milk ejection. So here are the breasts in different stages. So here's a mature breast but inactive during early pregnancy, mid-pregnancy, when they are lactating, and of course when it regresses after weaning. So these are the different stages histologically of a breast. So remember that all the ducts and lobules are going to be containing two layers of epithelium. So they're going to be containing a luminal cell layer as well as a myoepithelial cell layer. This is very important, especially as a preliminary before we talk about breast cancer in another video. Make sure you remember this. So in the alveoli, you have cuboidal cells at rest, columnar cells during lactation. Then the smaller ducts are going to be consisting of a single layer of columnar epithelium. The larger ducts are going to be consisting of many layers of columnar epithelium. Then the lactiferous ducts are going to be consisting of stratified squamous epithelium. So you have two epithelial layers in each of the segments of the breast, a luminal cell layer and a myoepithelial layer. The myoepithelial layer actually helps with the contraction and the pushing out of milk. So there is some blood supply, arterial supply, which is pretty much 60% coming from the perforating cutaneous branches of the internal mammary or thoracic artery from the subclavian. So it's going to the second, the third, and the fourth intercostal space. Then you have the lateral thoracic from the second part of the axillary artery, which is accounting for 30%, the lateral branch of the second, third, and fourth intercostal arteries. Then you also have the pectoral branches of the thoracoacromion artery and the superior thoracic artery. Then, of course, the venous drainage, you have the superficial veins from the breast that are going to be characterized by their proximity to the skin. These are going to be draining to the axillary, internal mammary, as well as the intercostal vessels. Then last but not least, we'll look at the nerves and the lymphatics. Remember that the breast is going to be innervated by the anterior and the lateral cutaneous branches of the 4th to the 6th intercostal nerves. Remember that milk is not only secreted under the control of oxytocin, or rather, milk secretion is under the control of oxytocin, but not nerves. But there is some psychological effect of release of oxytocin from the posterior pituitary gland in relation to what the mother sees. For example, if a mother that's lactating hears a child that's crying, this will signal the posterior pituitary gland to release oxytocin. This may actually even cause the breast to release some milk. Then the nipple is going to be innervated by T4. Then when it comes to lymphatics, which are very important, especially with inflammatory conditions, especially with cancer, the lymphatics are going to be draining predominantly into the axillary, the internal mammary, and the central lymph nodes. So remember, the axillary are going to be draining 80% of the breast, and the supraclavicular lymph nodes will be draining 20%. The axillary lymph nodes are going to be divided into groups. The anterior group, which is the main drainage node along the lateral thoracic, then the central or medial group, which is the next common, then the lateral, the posterior, and the apical group. We can actually divide these into surgical levels, which are known as Burr's levels. So this is in relation to the pectoralis minor. Level 1 is below and lateral to the pectoralis minor, so predominantly your anterior, lateral, and posterior groups of axillary lymph nodes. Level 2 is beneath or just underneath the pectoralis minor muscle, which are your central group. And level 3 are above and medial to the pectoralis minor, which are the apical groups. So remember that spread that is going to be limited to level 1 carries a good prognosis in terms of cancer. If it's going to level 2, it's going to be carrying a poor prognosis, while as those that are at level 3, this carries even the worst prognosis. So what about breast imaging? So we do a mammogram. So this is pretty much a plain X-ray of soft tissue of the breast using low voltage and high amperage X-rays. So there are 2 films that are taken, the craniocaudal, so from above downwards, and the mediolateral from the side to side. So remember, the mammogram is done in patients above the age of 35. In those below the age of 35, we often do an ultrasound. You may find microcalcification, which may signify malignancy. So they are less than 0.5 millimeters, pleomorphic, heterogeneous, grouped, sometimes fine, linear, and sometimes even branching. Soft tissue shadow may be smooth, round, oval, and regular in benign conditions or irregular in carcinomas. Then lobulated masses is usually suggestive of carcinoma. Then the size and location of the mass lesion, and then of course speculations and duct distortion may be features of malignancy. Then the margin may be well circumscribed in benign lesions. It may be microlobulated, it may be obscured, it may be ill-defined, it may be speculated, or it may be stellate. So here's an image of a mammogram that's going to be showing you, of course, calcification of a lactiferous duct here. And this is, of course, with a benign lesion. So remember, breast pathologies can be divided into congenital anomalies, inflammatory conditions, which we'll focus on in this lecture, benign tumors, which are pretty much your fibroadenomas and papillomas, and your fibrocystic change, which is your nodular lesions, cysts, and epithelial hyperplasia, and then, of course, breast cancer. Remember that a breast lump diagnosis usually varies with age. Fibroadenomas are very common in young women. Cysts are very common in women between 30 to 50, and then all new lumps in women that are above the age of 50 years old are considered to be cancerous until proven otherwise. So what are the inflammatory conditions that we'll look at? So we'll look at mastalgia, we'll look at mastitis, we'll look at antibioma, we'll look at TB of the breast, mammary duct ectasia, and traumatic fat necrosis. So we'll begin with mastalgia. So mastalgia just pretty much means breast pain. Remember, anything that's algia is pain. Arthralgia is joint pain. So mastalgia is pain in the breast. So the incidence is about 45%, and 21% is actually severe. Then most commonly, we don't really know what's causing this, and the mechanism behind this is poorly understood. And of note, it's not associated with breast cancer. Many people think that cancers are actually quite painful, but it's only in certain conditions. For example, if the cancer spreads to nerves or it's compressing on certain structures, that you may see pain. So mastalgia is often seen in patients on retroviral therapy, those that take caffeine, tobacco, and large pendulous breasts. So the pain can actually be divided into cyclical, meaning it's associated with the menses in 65%, non-cyclical, meaning it's not associated with the menses 30%, and in other cases, it may not even be in the breast, but rather in the chest in 5% of the cases. So we'll start with cyclical, which is extremely common. So this is pain that's going to be associated with the menstrual cycle. So when the discomfort is actually quite severe or prolonged beyond the usual 3 to 5 days, it often requires intervention. So this is just simply due to an increase in the fluid retention. However, diuretics have no role in the management. So even though you're thinking that, okay, maybe if there's some retention of fluids, let's give this person diuretics to help with lessening the congestion, but that's not the issue here. Remember that cyclic mastalgia is usually seen as an ANDI pathology, so ANDI just simply stands for aberration in normal development and involution of the breast. So it's an ANDI pathology, just like with fibrocystic adenosis. So it's presents in a woman of menstruating age, so they're just going to have this bilateral diffuse feeling of heaviness, this heavy feeling in the breast. So generally we just reassure the patient that it's a psychological condition. It's not associated with any increased risk of breast cancer. We can even give them some evening primrose oil, about 1,000 milligrams for 3 months. So it's going to be containing free fatty acids, particularly gamma-linoleic acid, and this has been shown to actually improve cyclic mastalgia. It is thought actually to be influencing lipid metabolism and improve the transport across intracellular membranes. So in cases that fail to respond, we can give them bromocriptine 2.5 milligrams twice a day, vitamin B6, B12, and analgesics. Tamoxifen can actually be given 20 milligrams 3 times a day for 3 months, but no clinical trials actually have been done significantly to support this. Then what about non-cyclical mastalgia? So other causes of breast pain are things like periductal mastitis, malignancy in some cases, cervical root nerve pain. Then you may also have musculoskeletal pain, previous surgeries, Tate's syndrome, which is a costochondritis. It is often unilateral. It's chronic, burning or dragging in nature, and occurs both in premenopausal and postmenopausal women. So 5% of the breast cancers actually present as pain during the first presentation. So generally we identify the cause and we treat the cause. We want to rule out any malignancy, tell them to avoid any coffee or stress, proper support to the breast. NSAIDs in some cases can be given. In Tate's syndrome, which is costochondritis of the second costal cartilage, it's commonly seen in females and it can actually mimic mastalgia. Then let's move now to mastitis, which is pretty much inflammation of the breast. Remember, anything ending in itis is inflammation. Uveitis, inflammation of the uveal tract. Mastitis, inflammation of the breast. So this can be divided into subareolar mastitis, intramammary mastitis, and retromammary mastitis. So it could be just underneath the areola, within the breast tissue, and in the retromammary space. So this is the potential sites where the abscesses can actually even form due to these inflammatory processes. So begin with subareolar mastitis. So this is due to infection of the underneath the areola caused by cracks in the nipple or the areola. So this results from an infection. So it's often associated with duct ectasia, which causes formation of abscesses, sinuses, and fistulas. It's common in non-lactating women. So what are you going to see? The breast will be red, inflamed, edematous, areola, and there'll be tender swelling underneath. Then, of course, the nipple may be retracted. So remember, nipple retraction is not just only seen in breast cancer. It may also be seen in some benign conditions. Then what's the differential diagnosis? Paget's disease of the nipple. How do we treat? So we cover them with antibiotics, flucloxacillin. Then if there's any pus, we drain the pus by making a subareolar incision. Then with intramammary mastitis, it can be divided into lactational abscess of the breast and non-lactational abscesses of the breast. So in lactational abscesses of the breast, obviously it's in lactating women. It occurs in 3% of women that are breastfeeding, usually up to 6 months of lactation. And the mode of infection is through the cracked nipples. So you have bacteria such as Staph aureus, which is most commonly entering through sucking or during sucking through the cracked nipples. Occasionally, it may also spread by hematogenous spread. Remember that Staph aureus is going to be causing clotting of the milk in the blocked duct, and then it begins to multiply. So the duct initially gets blocked by the epithelial debris or by the retracted nipple. Initially, it begins in one quadrant, but later it may actually even involve the entire breast. So what are some of the precipitating factors? Cracked nipples, retracted nipples, improper cleaning of the nipple, inadequate milk sucking by the baby, or milk expression causing stasis. You may also have infection from the mouth of the baby, even hematogenous spread. You may also have hematoma getting infected. What are the clinical features of this? So generally, this patient is going to be having this continuously throbbing breast pain and a high-grade fever. They may have features of inflammation such as diffuse redness, tenderness, warmth, and browny induration of the breast, and they may have a pus discharge from the nipple. So the entire breast actually may get involved. It may have tender fluctuation, which is seen in 10%. There may be ulceration and a discharge that can occur later on. Then, of course, it's difficult to differentiate the initial stage of mastitis, which is the stage of cellulitis, from the stage where the breast abscess actually forms. So when it's actually treated with antibiotics without actually you draining the pus, what you're going to be creating is what is referred to as an antibioma, where you're going to have this well-organized, non-tender, hard breast lump with sterile pus on the inside. So it's known as an antibioma. Then the differential diagnosis is inflammatory breast cancer. Remember, if you are suspecting that someone has mastitis and you treat them with antibiotics adequately and they still come back and it hasn't healed, then you should think of inflammatory breast cancer. So the treatment is antibiotics, cephalosporins, flucloxacillin, amoxicillin, or we can combine that with clavulanic acid. Can help. Repeated ultrasound-guided aspirations. This avoids surgery and scars. And then, of course, drainage and anesthesia. You should make sure you should do a counter incision. I'll show you what this looks like on a picture. Remember, it's not advisable to wait till the formation of the abscess. Often it takes a very long time to heal after surgery and causes distress to the patient and the surgeons. Complications include antibioma formation, sinus formation, skin necrosis, fistula formation, recurrent infections, bacteremia, septicemia. We can suppress lactation if required by giving bromocriptine 2.5 milligrams twice a day for 2 weeks. So this is the incision that you're going to be making, and you're adding a drain inside and then make a counter incision on the other side, such that in any position that the patient is in, the patient can still be draining the pus. Remember that indications for drainage in mastitis or breast abscesses is mastitis not resolving with 48 hours of antibiotics, then persistent fevers and progression of mastitis, browny induration, so do not wait for the abscess to form or fluctuation to develop. Then we have non-lactational abscesses or non-lactational mastitis. So this is common in duct ectasia and periareolar infections. Common organisms include bacteroids, anaerobic streptococci, enterococci, and gram-negative organisms. Commonly recurrent episodes of tender swelling under the areola can be seen, and this is often treated with antibiotics, repeated aspirations, drainage, and later a cone excision of the duct can be done. Then we have the retromammary mastitis. So this is often due to tuberculosis of the intercostal lymph node. Other causes include TB of the ribs, suppuration of the intercostal lymph node, empyema necessitans, and even infected hematoma. Often the breast is normal. Investigations that we may order include a chest x-ray, fine needle aspiration and cytology, ESR, peripheral smears, ultrasound of the breast and the chest wall, and often a CT scan of the chest may be needed. The treatment is largely directed towards addressing the underlying cause, and drainage is through a submammary or retromammary incision. When you talk about an antibioma, so if you have an intramammary mastitis, which is not drained and only treated with antibiotics, the pus actually becomes localized, it becomes sterile, so it has some flakes with thick fibrous tissue that can cover it, and this is known as an antibioma. So the patient may have previous history of mastitis that was treated with antibiotics alone, a swelling which is painless, smooth, non-tender, hard and fixed to the breast tissue without involving the pectoralis muscles and the chest. Investigations include an FNAC, mammogram, or ultrasound depending on the age. Treatment is going to include excision, so a submammary incision should be made. Later on, antibiotics are given, and whatever has been removed should be sent for histology. Sorry about that, my PC went off. So when you talk about TB of the breast, so this is a rare infection which can occur through blood or retrograde lymphatic spread from the lymph nodes. Here's an image of what it looks like. As you can see here, there's a undermined lesion. So often it's going to be associated with active pulmonary tuberculosis. It's common in lactating mothers. The nipple and the areola are not commonly involved, and it may present as a swelling of the breast with a cold abscess, a sinus, and typically a bluish appearance of the skin with matted lymph nodes on the same side in the axilla. The lump is often irregular, ill-defined, poor d'orange, discharged sinuses, matted axillary lymph nodes often with a sinus, are also noted, and one differential diagnosis is carcinoma of the breast. Investigations include a fine needle aspiration and cytology, a frozen section biopsy. It's quite useful to actually distinguish this from carcinomas, and excision biopsy. Treatment is going to be circling around antibiotic drugs, or rather antituberculous drugs such as isoniazid, rifampicin, ethambutol, pyrazinamide, and drainage of the cold abscess. Remember that mastectomy is not done. Then you may have mammary duct ectasia. This is simply just dilatation of the lactiferous ducts, which is often as attributed to myoepithelial relaxation associated with periductal mastitis. Because you have a lot of plasma cells in the periductal inflammation, this is also referred to as plasma cell mastitis. It commonly involves many ducts, and remember that the relaxation of the myoepithelium is often hormonally induced, and it's also coupled with poor absorption from the duct secretions and desquamation of the skin, causing obstruction, and they also are probable other causes and possibly causing the clinical features. It is an uncommon condition, and it's often encountered in porous women between the ages of 40 to 60 years, and it may present with a greenish discharge or creamy paste-like nipple discharge. Indurated masses can sometimes be felt underneath the areola, which are often tender, and one differential diagnosis is carcinoma of the breast. Investigations include discharge studies for cytology and a mammogram, which may show dilated lactiferous ducts. Treatment includes stopping smoking, cone excision of the involved major duct. You may also add antibiotics and a modified breast ductal system excision. Last but not least, we'll talk about traumatic fat necrosis, where there is a fibrous scar in the breast tissue which is caused by injury, hematoma, and necrosis of the breast fat with subsequent scarring. So it's seen in 50% of the cases, and it may either be direct trauma or indirect trauma. Sometimes a woman may not even notice. For example, she's in a car wearing a seatbelt, involved in an accident. Sometime afterwards, you realize that she has traumatic fat necrosis, or even may be playing a contact sport. Then these are often associated with superficial ecchymosis. Remember that in the pathogenesis of the condition, capillary ooze causes triglyceride in the fat to dissociate into fatty acids. Then these fatty acids can react with calcium through a process known as saponification, which causes an inflammatory reaction and later presents as a non-progressive swelling of the breast. Remember that this is going to present as a painless swelling in the breast, which is smooth, hard, non-tender, and adherent to the breast tissue. It may be bilateral and multifocal. It may be non-progressive and non-regressive, but later on may cause nipple retraction and slit-like retraction of the nipple due to fibrosis. Abscess and fistula formation can occur. It's common in smokers in relation to arterial pathology, and also common in multiple pregnancies, perimenopausal age, as well as hyperprolactin states. It often presents with mastalgia, and axillary lymph nodes may be palpable but non-specific. Secondary bacterial infections, often associated with aerobic organisms, are common. Investigations include a fine needle aspiration and cytology, which may yield a chalk-like fluid with fat globules, histology, which may show periductal cellular infiltrates and fibrosis, and a mammogram to rule out malignancy. Differential diagnosis includes carcinoma of the breast, and treatment is going to involve surgical excision to exclude malignancy. Here's our warm-up question. Phylloides tumor on histology might be benign, true, might be borderline, true, might be frankly malignant, true, and might have a cellular stroma, which is characteristic, which is also true. I really hope you enjoyed this lecture on inflammatory breast pathologies. If you did, consider subscribing and hitting the bell notification icon such that you never miss any of this content. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.